Hello, welcome on this Ethics, Health and Death 2.0 blog, also called the low-cost innovation and information blog, because guess what, my name is Cost. Okay, that was an easy one. And now it's not going to be an easy one. I'm going to talk about mechanical circulatory support in replacement of heart transplant, even for old people. So that may sound pretty technical, but it's a cardiac device, an implanted device, as a replacement to transplant. So you don't need the transplant anymore. It works. Surgeons know it as a fact, and it works even for elderly patients. Never heard of it? I'm not surprised. Why am I not surprised? Public information campaigns on heart transplant are, sorry for that, biased. Mechanical circulatory support is a better option even for elderly patients than a transplant. Yet the info the broad public gets is all about heart transplant, nothing about mechanical circulatory support. How comes? Those campaigns are financed for up to 60% by big pharma, immunosuppressive drugs. When you get a transplant, you need the drug. When you get treated with mechanical circulatory support, a device, instead you don't, because the device replaces the transplanted heart and the drug. Big Pharma has, on hands, no interest in patient education on mechanical circulatory support, understandably. Heart surgeons should start thinking again. It's time they get involved in patient education. Somebody has to do the job Big Pharma is obviously not doing. Unless you call this taking advantage practice of theirs, patient education. Medical liability includes the loss of chance doctrine. This legal rule applies to surgeons, but guess what? Not to Big Pharma. Mechanical circulatory support in replacement of heart transplant for old people? Wait a minute. This is a huge piece of crap, never heard of it, and I'm checking the info on the internet every day. Well, sorry, but it works better than a transplant, and surgeons know it as a fact. You may want to check the white papers on the internet under mechanical circulatory support as destination therapy. Okay, the surgeons know it as a fact, it works, etc., and yet they fail to inform us, the patients, the broad public. And this has been going on, guess what, for a decade, so nearly a decade, because technically it started in 2004, end of 2004, so nearly a decade. As a consequence, mechanical circulatory support remains underused and heart transplant overrated. Mechanical circulatory support is used only as bridge to transplant instead of replacing the heart transplant. So okay, we got the whole thing flipped around, we got it all wrong. We think device as bridge to transplant, mechanical device as allowing the patient to await the transplant, so as bridge to transplant. We never think this device can replace a heart transplant and become a destination therapy. So, awkward moment. Heart surgeons keep asking the transplant medicine community, are we ready for this new paradigm? Are we ready for this revolution? Are we ready to implement mechanical circulatory support instead of heart transplant? So, big change. People have to think out of the box, because the whole system of organ donation lies on the immunosuppressive money, the immunosuppressive drug money, so the molecule, Big Pharma. If you rethink the whole thing because of a device, well, you're not out of the woods. Okay, so in France, Pascal Le Prince, MD, PhD, head of cardiac surgery department, Pitié-Salpêtrière Hospital, Paris, suggests we aren't ready, and before him, one of the cardiac device pioneer, also a brilliant surgeon. So that was more than, let's say, 9 years ago, I'd say, asked the same question: are we ready for this revolution? And obviously we weren't. So according to PhD Pascal Leprince, we still aren't. He suggests at least we aren't. And he isn't the only one. Heart transplant has always been the gondola head in organ donation public campaigns. Quite a paradox, since worldwide's most sought after transplant organ is, or are, any hint? Any guess? Wild guess? Kidneys. Not heart. Not at all. Kidneys. Did you know that Big Pharma, worldwide leader on the immunosuppressive drug market, has been financing for decades and up to 60% of the total cost of these campaigns? Numerous organ donation public campaigns in many countries, including the US and Europe, of course. Heart surgeons have never been involved in fundraising for public information campaigns about mechanical circulatory support, for instance, that can be more effective than a heart transplant. Well, I'd say it's time these surgeons start thinking again, because, you know, medical liability includes the loss of chance doctrine. So we've got some, call it whatever you want, ugly truth or facts, that are starting to pop here, and we feel quite uncomfortable with them because we have to think out of the box. Up to now, doctors didn't need software, devices, computers to cure us. Well, you know, we patients always said, oh, well, this administration, the red tape, you know, these papers, how come they should have computers and the like. But all in all, doctors were able to cure their patients adequately without software, computers, etc. But I was talking about thinking out of the box. We've got a major paradigm shift here, paradigm shift or revolution, call it whatever you want. The thing is, doctors now desperately need computers and softwares and devices to cure patients. See what I'm talking about here? Well, you've got the 3D bioprinters, you know, these 3D printers printing biological stuff like skin, like bladders, and it works for transplantation use. Trachea, or even kidneys suitable for transplantation. Okay, they are not ready for transplant yet, but they are going to be in, say, in the range of 5 years, estimatedly. So I'd say we will have to think out of the box, and we will have to rethink the whole organization of replacement medicine pretty soon, because up to date, replacement medicine was, okay, organs, taking bits, parts from persons to cure other persons. And the whole system was based on the molecule, on big pharma, on immunosuppressive drugs. But now, here comes the genomics era, here comes the bioengineering era, here comes the 3D bioprinting era, and this is a totally new thing. My wild guess is that we might start learning some, oops, sorry, I'm gonna say it again, ugly truth about transplant as we experience it today. So this replacement medicine thing, taking bits, parts from people to cure other people. To start with, brain death. Brain death is the scientific concept, because it's fairly abstract. And on this concept depends the whole transplantation medicine. It's fundamental to the whole system. And guess what? Brain death is, from a medical and ethical point of view, flawed. Did you know that Japan rejects brain death criteria? They don't recognize it. They don't think they are accurate from a scientific and ethical point of view. Did you know that Harvard Medical School said in a meeting a few years ago, only among peers, only among specialists, that we could not say any more than that brain death was equivalent to death? So from a legal point of view, a brain dead person is a dead person, has no rights anymore, has not the rights of a person anymore, because it's only a reservoir of transplantable organs suitable for transplantation. But on the other hand, this same or a brain dead person is a dying person on the physiological point of view. So you've got two different things here. You've got the legal point of view, the person's dead, not a person anymore, not the rights of a person anymore, only a reservoir of vital organs. And on the other side, so physiological point of view, you've got a dying person, and then comes this next of kin organ donation decision. You know, this next of kin organ donation decision thing. People feel they're being robbed of something very precious, which is the guarantee, the feeling that their beloved one died in a peaceful way. Because you know, organ donors, so dying persons, are not always given an anesthesia. Their muscles are being numbed, so they are kind of paralyzed, but they are not always given an anesthesia, because they are supposed to be dead. But awkward moment, technically speaking, organs from dead bodies won't cure a soul. So wait a minute, doesn't make any sense. You've got two kind of death here. So when I heard somebody passed away, I'm gonna say, oh, did this person die white or did he die pink? You know, because specialists call brain death the pink death. Seriously, guys, you can't say there are two kinds of death. So the whole system is not sound, and you will have to rethink the whole thing. So I'm curious to see where we will be headed in a few years, because we've got this genomics tsunami that is rolling over to us. And some people just don't see it, but I think we will have, seriously folks, I think we will have to think out of the box pretty soon. And I'm coming back from Harvard medical courses or sessions, and I can tell you some serious guys and some serious businesses have started thinking of the box very, very seriously. And lots of disrupting things will happen in medicine. Medicine was pretty much doctors and molecules, pills, until now. And guess what? Now we'll have data, small data, big data, we'll have genomics, we'll have nano biotechnologies, you know, these all NBIC, let's say everything coming together. So nanotechnologies, biotechnologies, computer science, cognitive science, brain, etc. And you know, we witness these say disruptive facts or big changes coming right under our nose, totally unprepared. Nobody can be prepared, but I know for a fact that brain death is not gonna last for long, and I think brain death is pretty much dying. So thank you for your attention, and hope to see you on the next video for a new bioethical chronicle. Thank you.